Oh, wait a second. Thank you, Fola. We do have a certificate of attendance available for you. If you'd like a certificate of attendance, about halfway through the webinar, we'll post a link in the chat box. Click on that link. It'll take you to a form, fill out that form, and within a couple of minutes, boom, you've got a certificate in your email. And yes, that's everything for now. All right, then, on to the real reason we're all here today. I'd like to pass you over. Shall I pass it over to you, Erin, to introduce the team and get us started with the presentation?
I'll share my screen and pass it off to Phoenix. Hold on one quick second. Okay. Off to you, Phoenix.
Just sorry, folks, just give me 1 second here. There we go. Good morning, everyone. Welcome to our presentation on Imagine Safe Supply. Our research is carried out with the Canadian Drug Policy Coalition at Simon Fraser University, which is located on the stolen and occupied territories of the traditional Coast Salish lands, including the Squamish, Tsleil-Waututh, and Musqueam nations. Just touching on what Rebecca said earlier, we would like to note that prohibitionist drug policy is an active and ongoing arm of colonialism in Canada. And we start with the understanding that notions of safety may have nuanced and specific meanings for First Nations, Indigenous, Métis, and Inuit people. Through partnership and openness to learning, we work with the intention that safe supply may become a meaningful part of reconciliation where there is interest and need in that, and that this requires transparency and commitment on all of our parts. Also a note that we may use the terms drug user and people who use drugs interchangeably in this presentation out of recognition and respect for people's various personal choices and identities. Next slide, please. The principal investigator for this research is Donald McPherson. Canadian drug policy research staff include graduate research associates Karmveer Pata, Jack Farrell, and Sean O'Callaghan, and our senior research associate, Erin Howley. This research is co-led by the community research associates, Celine Coate, Frank Critchlow, Erica Schoen, Nikki Schell, and myself, Phoenix Beck-McGreevy. Next slide, please. Our research question asks, what are the attitudes and perceptions that people have about participation in safe supply for both people who use drugs and frontline workers who are directly working to support people who use drugs? In this research, we consider safe supply centering the choices of drug users and to be different than models that focus on reduction or abstinence of drug use. We wanted to hear about the gaps between current access to a regulated supply of drugs, which could include OAT, IOAT, stimulant replacement therapy, and prescriber or community-mediated safe supply, and what people desired in a safe supply. And I'm going to pass it to Erin.
Thanks, Phoenix. I'll just share a little bit about our demographic cohort. We recognize that access is unequal from province to province. This is important to keep in mind. And we did hear about different levels of access to safe supply or regulated supply in this research. So just a note, the overall data set for Imagine Safe Supply had 55 key informant interviews from across the country. 40% of our data set was with First Nations participants. This research is taking place through a partnership with Thunderbird Partnership Foundation, which is stewarding and leading data analysis on the First Nations part of the data set under OCAP standards. So just to be clear, the presentation that we're giving today pertains only to the non-First Nations data, which includes 33 participants from across BC, Alberta, Ontario, and Quebec. Our recruitment criteria for this research were that the participants used opioids or stimulants at least once a month for the past year, and this could be in combination with polysubstance use, or that participants worked at least 10 hours a week in frontline work for the past year. So we were talking to both an overlapping group of people who identified as drug users and frontline workers. Important to note is that 70% or 23 of these participants identified as both drug user and frontline worker. So the strength of this data is in its overlap between people who will be accessing safe supply as well as working within care and service settings. The data is reflective of the resounding representation of people who use drugs within the frontline labor force. This chart shows the participants' drugs of choice for those who identified as drug users, and you can see we did recruit for opioid and stimulant use, and that was in combination with preferences for benzos, alcohol, psychedelics, and cannabis. Then people who identified as frontline workers in the research said that they were doing harm reduction work, outreach, shelter and drop-in work, crisis response, and street or community nursing. In terms of the demographic size of the residents of the population size of the cities and towns where we talk to people, 21% of participants lived in towns under 100,000 people. 33% lived in towns between 100 to 1 million. With 21% of those in towns that were between 100 and 500,000. And then 45% of participants lived in cities over 1 million. So accordingly, this data did include input around rural considerations for safe supply. Just under 58% of our participants were female cisgender. Just over 39% were male cisgender, and one participant identified as gender fluid. Participants further identified as unhoused, Black or Afro-Caribbean Black, a person of color, LGBTQ2 spirit, and Indigenous or Métis within the intake survey. And in keeping, the interview data from our key informant interviews reflects demographic findings for these subgroups, in addition to sex workers, parents, and youth. So Imagine Safe Supply does include findings about the need and importance of cultural inclusion and demographic concerns within safe supply, which is important because, for example, we heard about aspects of why safe supply could be considered racist or exclusionary, which we'll be getting into the significance of exclusionary aspects of safe supply. So this is a bit of a snapshot of the percentage or number of participants who identified in these subgroups. Our age groups, the majority of participants were between 30 and 49. 18% were under 29, 30 were between 30 and 39, 33% were between 40 and 49, and 18% were 50 or older. So the project speaks to current and desired safe supply. We wanted to know generally what kinds of regulated supply people already had experience with when they talked about current access to regulated or safe supply. So of our participants, 15 or 45% had some experience with agonist replacement therapy. All of those had been on OAT, and then a subsection of them had also had experiences with IOT or stimulant agonist replacement therapy. And then some folks said that they had experience with doctor prescribed safe supply non-agonist, so not OAT essentially is what that means. We didn't ask people what kinds of prescriptions they were on, so that came out more, that got fleshed out more in our key informant interviews, but 13 participants said they had experience with doctor prescribed safe supply, and 7 said that they had experience with some kind of buyer's club or compassion club or community distribution. And I'm going to pass it off to Sean.
Thank you, Erin. So one of the central aspects of our findings was a discussion among our participants of community values of people who use drugs. Now, our participants talked about a number of different values, but we're going to focus on 5 today, which are up on the screen right now, which were community and relationship building, autonomy and self-determination in choice making, cultural inclusion, trust, and mutual care. So in defining what we mean by values, we understood values to be beliefs and norms that inform our actions and are part of drug use culture and relationships. We propose that no matter the safe supply program or service, we can trace it back to a set of core values. And it's important to note that the values informing current models, which are largely medical, may not match up with drug use community values. And by bringing these values to the forefront, we can generate more nuanced and hopefully mutual conversations about what kinds of safe supply models and outcomes make sense. We'd like to pose this orienting question. How can we bring safe supply in line with community values of people who use drugs as a starting point for our conversation today? So this is an important question because in this research, we heard from many of our participants about how people who use drugs are frequently talked about how people who use drugs are expected to fit within a box of criteria and expectations, which are so often established by government and healthcare institutions in order to access prescribed safe supply. This box determines who is excluded and who is ignored, and it really relates to ideas like racism, marginalization, and stigma, as well as the pressure of what is expected from people who use drugs to participate in these programs. These constraints are made worse when people are low income. For example, the expectations around abstinence that go along with shelter and housing supports and lead to increased stigma of both poverty and drug use. These boxes are at odds with the community values that our research highlights. So one of the core purposes of Imagine Safe Supply was to look at the gaps between current regulated supply and desired safe supply. People discussed current and desired access in really detailed ways, and they touched on all the different sort of aspects of programs that you see on your screen right now, including drug options, drug dosages, eligibility, program design, methods of consumption, program locations, how prescriptions are picked up or delivered, and how participation in these programs feels. We have a lot of detail on every one of these areas, and we're still working as a team to synthesize our findings. But for today, we really want to focus on a few topics that really relate to the box that people who use drugs described and can help us to consider what that experience is like and how prescribers and safe supply providers can contribute to removing that box. We're going to focus on three major areas of our findings. One, related to the repurposing or resale of prescribed drugs. The second, related to safe supply eligibility. And finally, about prescriber relationships with people who use drugs. And I'm going to pass it off to Jack now.
Thanks, Sean. So to begin, before we talk about the content of this topic, I just want to have a quick note on the language we used. So repurposing and resale of drugs is more commonly known in prescriber models as diversion. However, we chose to reframe this language. And we made that decision as the term diversion is stigmatizing and fails to reflect drug user perspectives in our data, namely that repurposing of prescriptions often happen as a practice of care in communities of people who use drugs, which is opposed to the narrow conceptualization of this practice that's expressed usually in the term diversion. So many participants challenge the idea that repurposing is something to be completely avoided, because there are benefits of repurposed drugs for communities of people who use drugs. Policies meant to curtail repurposing, such as limitations on carries and observed dosages, were experienced to be coercive, limit patient autonomy, and undermine the patient-centeredness of safe supply programs. Participants discussed the role of prescribed safe supply programs themselves in driving the repurposing and reselling of prescriptions, because they don't sufficiently meet needs around drug options, doses, and access, as well as lack of wraparound support such as housing and food security. Although often portrayed as a patient problem, repurposing was actually seen as connected to safe supply retention and a value of mutual aid. Several participants spoke about how repurposed prescriptions are a means of supporting their communities to overcome prescription-related adversity. For example, if someone can't pick up their prescription, they can still access the regulated doses instead of diverting to the street supply. Speaking more to this point, participants noted that without access to repurposed prescriptions, a person's engagement with safe supply programs currently can completely fall apart if things don't go exactly to plan, which in the context of a drug toxicity crisis can be deadly. Participants also described how repurposing is used to facilitate initial engagement and access to prescribed safe supply for communities who did not yet have access to it. Considering these points, then, we can think of repurposing as a temporary band-aid solution to help increase access to inadequate forms of safe supply. Repurposed prescriptions were viewed as a form of community caretaking that is aligned with drug culture values of mutual aid and support in a time of crisis. Repurposing is an immediate step that can be taken by people to help address the toxicity of the unregulated street drug supply. So considering this, we can look at repurposing and resale as positive, life-saving interventions, not necessarily as a negative personal behavior. So to kind of wrap up this area, I'm going to pose a question. How could this reframed perspective help make drug access more collaborative and community-based? So-called diversion often has the effect of blaming drug users for systemic problems. We can reframe diversion as a limitation of program needs, of program models rather, and a factor of constraints due to professional liabilities rather than a problem with the person themselves. Repurposing or diversion is often seen as a personal issue, but we'd like to suggest that it really points to a lack of accountability on the system. We can also use this viewpoint on resale and repurposing to give us good perspective on the role of community networks for safe supply education and uptake. It's really important to highlight that safe supply is a community effort. And I just want to wrap up this topic now with a quote from our research. And this quote points to the notion that repurposing of drugs is an urgent and sensible strategy. I really want to push prescribers off of this issue of diversion. Like, come on, if somebody is using something that didn't come off the street and is actually pharmaceutical grade, that's a win, right? And also to do things differently and respond to the crisis with the speed and gravity that is called for. I mean, there's many jurisdictions where we've lost more people to overdose than to COVID. So let's go. While we can reframe repurposing of drugs as a positive aspect of mutual care, it also points to the importance of expanding accessibility and more open eligibility criteria. And so on that notion of eligibility criteria, I'm going to pass it over to Phoenix.
Excuse me. So in this topic of eligibility, participants spoke about the need to demonstrate an attempt to undergo drug use therapy or treatment such as OAT, or to enroll in concurrent methods of treatment in order to access safe supply. As well, they were required to perform, to audition, and to fit a specific mold to access prescribed safe supply. They had to work to convince prescribers that they deserved these prescriptions. A defining characteristic of the mold that participants described was the unrealistic need to convince prescribers of their vulnerability, their disadvantage and marginalization, and their high risk of drug poisoning harms. Sorry, lost my place. Participants who did not fit neatly within this patient mold said it was difficult to be enrolled within prescribed safe supply programs. There were descriptions of prescribers seeing people as too stable to prioritize for safe supply. For example, having housing and a job made people be seen as being too low risk for overdose. As a point of discussion, the medical system has historically preferred to make interventions accessible to individuals that are considered to be responsible drug users and who have a good chance at retention. But current safe supply in prescriber models appears to be flipping this notion on its head and can lead to conflicting expectations for engagement with healthcare systems. And one thing that we should keep in mind is that these tightened criteria and difficult accessibility is often due to a lack of availability. I'm really sorry. I seem to have an old slide deck. From these points, we can interpret that safe supply eligibility constraints impact the quality of relationships between people who use drugs and prescribers. We find the following quote to exemplify this issue. It shows the relational dynamics at play with prescribers around current access to safe supply. One participant said that safe supply needs to be actually out of the hands of the medical system. It is utterly my belief, because every interaction that people have with the healthcare system as it is currently, it's very often an audition, and there can get to be an antagonistic relation that happens. Do you deserve this? Do you deserve my help, my attention, And I honestly think for safe supply that having prescribers as the intermediary won't do. This quote shows a wish to disengage from prescribers. This is important because current issues around prescriber-mediated safe supply eligibility have the potential to further alienate people who use drugs from healthcare systems. Participants described the desire to see programs disrupt the current mold of who is considered a candidate for safe supply. There was a demand for universal eligibility regardless of life circumstances. And considering the toxic drug supply, participants wanted eligibility to be based on the need or wish to access a regulated drug supply and to avoid criteria that are exclusive. This desire for universal eligibility can be seen in connection to the values of mutual care and community relationships that we've already been talking about. In contrast to expectations that people pursue abstinence-based goals, one participant detailed wanting programs to support a more holistic and person-centered goals in connection with safe supply intake, such as reconnection with family members, being able to travel, being able to, hold down employment. Recommendations for removing the box from around drug users can include holistic approaches to eligibility and program intake that focused on inclusion and a range of desired supports. Separating eligibility from an expectation for reduction in drug use or enrollment in treatment. Involving people who use drugs in the program intake process. Engaging in conversations that are omnidirectional and are more mutually collaborative around drug use preferences and life goals is very important. Considering the role of prescribers in advocacy for a regulated drug supply, including prescribers taking on the willingness to address unequal power dynamics within processes for drug policy change. That could look like advocating among your coworkers. That could look like, attending more of these sorts of webinars and just taking on that readiness to use your personal power to advocate. One participant said, I really think that anybody who is at risk of overdose should be eligible for safe supply, no matter their age or socioeconomic status. If they're homeless or if they're housed with a job, I don't think it matters. And as for the criteria to stay on, I think if they're showing, improved outcomes in any area, that should be enough criteria to stay on. If their health has improved, if they're rebuilding relationships with their family, if they've gained housing after being on safe supply, any of these indicators that they're becoming stable and it's working well for them, that should be enough to keep them on. I am sorry, I have an old, thank you. I'm going to pass it on to Frank now. Thank you for my stumbling through.
Thank you, Phoenix. Today I'm going to talk about the relationship between prescribers and people who use drugs. There's an imbalance between people who use drugs and prescriber drives. And the narcissistic relationship reinforces the need for people who use drugs to audition for care. Participants felt that prescribers often oppose or discourage people using drugs from experiencing pleasure. This has serious consequences for the capacity of prescribed safe supply to meet the need of people who use drugs. Even in contexts where safe supply prescribing is supported by provincial regulatory bodies, many participants encountered prescribers who are hesitant or outright unwilling to engage in this prescribing. Still, participants recognize that the impact that regulatory colleges and government institutions have on relationship between prescribers and people who use drugs. There was concern and fairness in considering the regulatory pressures prescribers are faced with. Participants saw how supportive prescribers are also in the box by the current system. In note, when participants talk about desired relationship with prescribers, this did include descriptions of empathy, exemplary prescribers with whom they have had a good experience. One way to improve prescribers with people who use drugs relationship is to foster authentic participation with people who use drugs. This includes shared decision and feedback, active collaboration, strategies to disrupt traditional power dynamics, new and sustained partnership. This notion of pleasure is so stigmatized that it undermines the ability for safe supply to be successful. By considering what doses will provide satisfaction and pleasure, this can shift the relationship in a more receptive direction. Positive prescribers' relationship genuinely center the needs of people who use drugs, making deliberate efforts to accommodate people's unique circumstances. Desired relationship with prescribers would feel inclusive, show curiosity, compassionate, non-punitive, empathetic collaboration. All this raises the question, how are prescribers accountable to people who use drugs? There is currently a great deal of criteria for people who use drugs to access and stay on safe supply. On the flip side, there can be positive criteria for prescribed involvement so that safe supply is keeping with community values. Having a two-way street on criteria for collaboration and involvement could be a pathway to address unequal power relationships. This likely means reformed prescriber roles and duties within the safe supply provision. With this premises that safe supply can be rooted in drug leadership and decisions, making it helpful to consider the accountability framework for prescriber involvement. Over to Sean.
Thanks, Frank. So bringing it back to the core set of community values of people who use drugs that we started the presentation with, we can see how these barriers around repurposing prescriptions, eligibility, and prescriber relationships can really be thought of as a lack of alignment between current practices and the current values within prescribed safe supply and the community values of people who use drugs. As a recap, Imagine Safe Supply data showed a great deal of discussion within these 5 community values up on your screen right now. And by refocusing prescriber-led models of safe supply in a way that centers this value system, we can start to explore improved approaches to safe supply. So this was our orienting question. We're going to bring it back to it. So how can we align safe supply with the community values of people who use drugs? So in moving towards an alignment of safe supply and the community values that we've outlined, we'd like to propose that our shared goal be to build safe supply communities that are focused on practices of care. Drug users should be at the center of this reformed approach. The great news is that this is already happening in some parts of Canada, and it can be honed and improved upon. A shift to focus on community values can encourage prescribers to come to the table as a mutual stakeholder in drug user-led processes. In these new processes, prescribers may carry new or altered responsibilities, especially considering the need to urgently address current inequities in power and decision-making that dominate prescriber-led models. Based on these findings, we would like to propose some programmatic ethical standards that can help us understand what it means to create safe supply communities based in accountability to people who use drugs. So here we consider several questions that help to demonstrate these ethical standards, and safe supply programs and providers can consider these questions in relation to their own programs and services. For example, how does this program prioritize drug user organizing, leadership, connection, and community building? How is this program based on inclusive processes for decision-making and feedback? And how can these processes be improved? How does this program create options around confidentiality and desire to respect the rights and needs of all people? In what ways, if any, does this program center cultural inclusion? How does this program respond to the different reasons that people use drugs? How does this program address racism and discrimination? In what ways does this program involve personalized and collaborative approaches to safety and care? And finally, who leads and staffs this program? What is their level of decision-making power? And what is their relationship to local communities of people who use drugs? And finally, we'd like to pose some framing questions for our dialogue in the upcoming question and answer session that help us to consider the notion of safe supply communities. We're going to post these questions in the chat as well, so you can take some time to digest. And thank you very much for listening to our presentation.
Amazing. Thank you. There's lots of hearts and applauses happening, I see. I'm just going to launch very quickly. I'm really looking forward to bringing, you've just brought up so many great things. And I think there's a lot here for us to talk about. And I'm really excited that we have time to have a really good conversation. I'd really like to encourage everyone to put questions and items for discussion in the question and answer box. We'll get to that. Just before we turn to that, I need to do a little administrative thing. I'm going to launch a poll and ask everyone to just complete this poll for us. This poll helps us with our programming, and then also our funding. So if you could just fill out that poll for us, it'll just take a minute. But let's continue on. Let's pull up the questions. Okay, we don't have any questions in our questions and answers yet, but I'm certain that this presentation has people thinking. And I'd really like to invite, if you're not as comfortable, if you're more comfortable speaking, please raise your hand and we will unmute you so that you can join into, and we can have more of a conversation. Okay, I'm going to start. One of the things that really excites me about, given the fact that due to our current regulatory legislative context, the focus right now has been on, or what's been implemented thus far, predominantly has been a prescribed model, right? And one of the things that excited me about a prescribed model was this possibility of, to use your terms, imagining or reimagining relationships between people who use drugs and healthcare and social care providers. How could that how could those relationships where people have often experienced so much stigma, frustration, denied access, experienced violence in those relationships, how could those relationships be recreated, reestablished? And I think that this is what one piece that your work is looking at and talking about here. Did you come across examples where from people where they did talk about having different types of relationships with healthcare providers than they had had previously? Is there hope in that regard? I mean, I know there's some amazing providers out there who, but in terms of, do we see a bit more of a movement that this could move beyond just the provision of safer supply to improved relationships between healthcare providers in general and for primary care and things like that?
I'm glad to start us off. And then, I mean, our whole team we've been working on this project for 3 years now. So I'm sure the team can talk at length. But yeah, like Frank mentioned in the presentation, there were descriptions of good relationships. And one of the most interesting codes, I think, of our entire data set, our findings, was on how safe supply feels. What does it feel like to be involved in this system, this process rather? And part of the description of current safe supply was some description of those relationships. And then, like Frank mentioned, empathic, curious about people's experiences, very personalized. Some people expressed the more of a wish for a long-term ongoing engagement, but that's also at the same time, some people want no engagement with prescribers. And safe supply needs to be considered a whole array of options so that people can choose how they want to participate or not, and not be excluded because they have other interests other than, engaging with prescribers. And I think, there was a wish for better relationships. Unfortunately, it seems like the way things, like overwhelmingly in the data, the way things are set up is that safe supply contingencies might be negatively affecting people's relationships with prescribers, which is what we don't want to see. And there's a need to address eligibility criteria and the leadership and involvement of people who use drugs in these programs in order to steer this in the right direction. And I think overarchingly, and then I'll pass it off to my team, the notion is that it's not prescribers leading safe supply, it's drug users. And then you fold prescribers into drug user-led processes in ways that the community wants and that makes sense and that feel consensual. And so what we're proposing is that, in talking about a safe supply community, is that prescribers are coming to a table where everybody is involved in deciding what should those roles be and what that should look like. I'll pass it off to the rest of my team to add on.
Yeah, I mean,
sorry.
Go ahead, Frank.
I agree with what Erin said, but still there's a disconnect with prescribers and people who use drugs, especially when it comes to the Black community. With those who use drugs, that is part of the disconnect. There's a lot of racism towards Black people who use drugs. And if they're not meeting the needs of everybody, because people are not getting what they want, especially when it comes to pleasure drugs.
Yeah, and I mean, personally, I've had good experiences with providers and, I've had negative ones. But I mean, a lot of what our data is saying is that people just want to be included in their care plans. They want a more collaborative approach. They just don't want to be lectured to and spoken down to by their prescribers about what their goals are, and goals were something that was really aligned with the values. Like, the goals of the people who are going to be participating in this program might be different from what their prescribers think it should be. Some people felt that their prescribers were more geared towards like a treatment or abstinence model, whereas they wanted to continue to use drugs, but in a more safe way. And so really taking that notion of autonomy and like just expanding that into prescriber relationships where you can talk honestly with your provider. You don't have to lie to them as a method of protection. You can just be honest and say, like, this is what I want, this is what I've used this week, this is what's going on, and how can we collaboratively make a care plan that fits both of our needs. Because as a drug user, I understand that doctors and prescribers and pharmacists have regulatory bodies that they report to, and there's a lot of fear of licensing being taken away and things like that. And I don't want to be the downfall of somebody's career, but I also don't want to have to give a urine sample every time I go in, when I'm being perfectly honest with my doctor about what I'm using. And so, and I mean, further towards the idea of prescriber involvement, there's really a lot of room there, as I was saying in the presentation, for advocacy for people that are in these fields, in these careers, to be doing personal one-to-one advocacy among their colleagues, and to larger groups and that sort of thing, because they have a lot of personal power and a lot of cachet that they can use to forward these these ideas of safe supply.
I just add one thing, kind of echoing what everyone said, is that you asked if there's hope. There definitely is, but I think the hope comes from not just relying on individual prescribers to learn more themselves. The hope's going to come from actually implementing system change and implementing basic standards, minimum level of ethical standards, so that it's not about the individual personality of the prescriber, it's about what they are obliged to do. Because I think we need to get away from the idea of mean or nice prescribers. That's not the point of system change. It's about implementing systematic change. So that's where the hope lies.
Thanks
Right.
for.
Yeah. And that accountability, if there's like one word, it's accountability. And the question is, like, how are prescribers, like Frank said, how are prescribers accountable? And you could break down accountability into a lot of different processes and considerations. But part of it is that there's criteria for prescriber involvement, just like there's criteria for drug user access. And that those kind of accountability processes would need to come from the community.
Thanks for adding that, Erin. I think that's an important piece too. And just going back to what you were saying, Jack, around to me, it's also around how we think about substance use in general, right? In terms of if substance use, like a substance use disorder, is a brain disease versus the problems happening that people experience related to substance use coming from social structural factors. And so while we think of substance use or addiction as a brain disease, there's all this need for like controlling people to take care of them, and it's very paternalistic and monitor, control, make decisions for them. So how do we break away from that? And I think the study that you've done, that you're sharing with us all now and highlighting these practices of care and these community values, and is really doing a great job of countering some of that stigmatizing kind of vision or idea about people who use drugs that has dominated the field, particularly addictions medicine, and sort of larger in the public, in society. Yeah.
I mean,
go ahead.
Sorry, the other thing too is that, like, drug users have a really hard time accessing primary care. So to have a one-stop shop sort of thing where they have a doctor that is dedicated to their whole care of their whole self, that could be life-changing for people. Because I mean, like, just anecdotally, I was working at the OPS the other night, and a woman came in for wound care and was asking us for like pretty heavy medical wound care. And like this kind of thing happens all the time in the downtown east side particularly, and I imagine in other areas with drug user communities, is that people are not getting the care that they want or need from traditional medical systems. So being able to have a medical system that addresses all of the needs that people who use drugs have, that their bodies and their minds need help with, would be, you know, like in the presentation, we talked about a holistic notion of care, and that just really, it comes up so often.
One thing I'll add to that is one of the things, one of the areas of current and desired safe supplies we heard about was program locations. But it's like, what does it feel like? What does it look like? And there's a number of different ideas, all the way from people being informed, like kind of thinking about current clinical spaces that they actually have access to versus dreaming, desiring, imagining. And it's a theme that came up again and again. It's like, how do people imagine something they don't have access to? And there's so much violence and barriers in place of how do you imagine safe supply? What does that even mean? That was an interesting task that we navigated and having conversations with people, and is a finding in of itself. But sometimes these program locations were like houses where people, was it like for drug users, where you think about the whole logistic of it, and it's not based out of a clinical setting. It's based and also in terms of cultural inclusion, the kinds of neighborhoods and the aspects of confidentiality that go along with how it feels. How does safe supply feel for people? So thinking about the role of prescribers, it's like, how would prescribers go into more of like a community oriented or community located process, where they're coming in and overlapping into a whole system of relationships and community, that's a drug use community that's already there and quite strong and relational. And how do you build on the forte of those relationships that are already, of the caretaking and mutual aid that's already there? It's already there. It's such a resource that shows up within quote unquote diversion. But if you think about that as a benefit and a resource, well, how do you build on that? How do you see that as a benefit and overlay holistic medical care into those relationships without exploiting them in a consensual way? So it's kind of like a one, and there's a lot of different models. There's a lot of probably different ways that people thought about safe supply happening, which we look forward to reporting on. But that was one strong point, is how it feels. And oftentimes it feels like relationships, like strong, trusting, mutual relationships. Yeah, I don't know if anybody wanted to talk about the whole thing about current versus imagined and what it meant to talk to people about what it means to imagine safe supply.
Yeah, for sure. During the interviews, one of the things that I encountered a lot was participants starting to dream and starting to say like, oh, it would be cool if we could do this, and then immediately shooting themselves down. Oh, there's no way, we could never do that. And so really trying to overcome that self-imposed limitation, that barrier, that, again, the box that people just begin to do to themselves after so long of being put in this box. And it's really sad to see that, you know, people who've been abused and marginalized for so long just immediately begin to blunt those dreams when they come up, because it's never been allowed for them. So when people were encouraged to overcome that, it was really beautiful, because like Erin said, one of the safe supply models that came up over and over again from a number of different people was this idea of a space for drug users, a place where they can go, where they can get safer drugs, where they can use them, where they can hang out, where they can get off the street, where they can do all sorts of things that have different sorts of community connections and care connections that they can access and take advantage of. But really being cemented in this forefront of like drug user owned and operated, and not, you know, not imposed on them. And that's something that I think has tried to be done a few times, and in some places it might work, in some places it might not, but really allowing people the opportunity to just imagine what they wanted and just to sit and daydream about what could be for a little while, I think was really hopeful and maybe helpful for people.
Right. So one thing we're hoping in sharing this research is to put the question back to whoever who might want to take it up. You're welcome to add it in the chat or discussion. is like, what would a process look like where you're inviting drug users in your community to imagine what safe supply looks like? How would you set that up? Like, would you have focus groups? Would it be more like where would it happen? Who would facilitate it? How long would it be? How would it be resourced? There's all kinds of questions you can ask about how do you understand more about how the people you work with imagine this thing, versus being like, here's what's on offer. You can't get on because this or that, or you can get on with these conditions. You know, we have, you know, it's like, well, what do you want? And like Phoenix was saying, some people were like, some people didn't know what to do with that question. And it took a lot of encouragement in sort of this unusual situation when you're talking to a stranger about something you haven't even thought of. And so some people stayed really close to what they already know. And some people were like, okay, well, if you really want to know, this is what I think. And it was interesting, the range of ability to imagine. An indicator of success or an evaluation could be collective imagining. I'm just like, it's sort of a strange thing to think about, but like, how have people's thoughts about safe supply changed over this interval of time, you know, and how much have people been able to realize those thoughts in practice? It's like, if you think about a model of safe supply as being rooted in community values that we talked about, your evaluation of safe supply programs might look really different. A core evaluation would be, what is the leadership and decision-making, changes in leadership and decision-making on personal and collective levels for the community, is a central aspect of safe supply evaluation.
I mean, in Vancouver, I've been lucky enough to take advantage of the Dolph Compassion Club model that's recently opened up. And I mean, it's a great model, but unfortunately, just due to staffing and financing constraints and legalization and criminalization concerns, it's only been able to be open to about 40 people. But it's really like, it feels a lot like what a lot of people said they wanted. You go in and like, and outside of the prescriber model, you go in, you buy the thing, you can use it there, you can take it with you. There's not a lot of oversight. It's just really like a basic provision of services in a non-coercive environment where it doesn't matter who you are or, you know, what your situation is or why you want it. You can just go and just get it. And I think that that's the start of something great. Oh, it's the Dolph Compassion Club, DULF, Drug User Liberation Front.
Thanks for bringing that, for bringing up Dolph and the type of service, the type of space, the type of care that happens there. Because I was wondering, like, how, you know, is that the kind of vision? I mean, that's where my brain starts going, right? A Dolph with maybe some healthcare providers who are invited, chosen, selected, invited to come in to be available to people sometimes, but not necessarily there all the time, and not required for the provision of the drugs. I'm curious about your own experience as a research team with this, grappling with this question of imagine safe supply. How's your own vision changed through the course of doing this work?
Well, I feel like I've been talking too much, but I'll just keep talking. For me, it felt really powerful to talk to other drug users and to talk to frontline workers who had a lot of experience and a lot of compassion, and you know, who are already on board. But one part of the research that we didn't have a chance to get to was posing the question of imagining safe supply to prescribers and pharmacists. And I feel like that would be a really interesting place to take it, but it took, like we've been saying, it took a lot of encouragement and a lot of really careful and well-crafted qualitative research questions to to draw the answers out of people.
That would be really interesting. We do have a
Yeah.
question.
Oh, I would say, I mean, I think that's a question all of us could probably answer in really different ways. But for me, it was seeing the wide array of what safe supply can be and how contextual it is, how connected it is to the location or the region, the political constraints in different provinces, the issues of rural access and culture, cultural inclusion. And, Frank could probably speak to this more because we heard some really powerful accounts from the Afro-Caribbean Black community, but also from parents, from youth, from women, from sex workers about the specificities around what safe supply needs to be. And so it's just so hyper contextual. To me, I saw, okay, well, this is the processes of community engagement. And it will be fascinating to see how this evolves across the country over time. But just like pausing there, anybody on the rest of the team want to respond to that good question? What was the question again, Rebecca?
I just wondered about your own journeys, about imagining safe supply. We do have a question in our question and answer, our question box. So someone asks, how does the research findings relate to youth? What would you respond to people who think a community model would make it easier for youth or teens?
I'm not sure, like, would make it easier for them to access drugs, or just like easier to access safe supply, or like, I'm not sure if the question is asking about enabling or
Facilitating.
Yeah, so in a positive way. Okay.
I'm not sure either, but
okay. I'm going to take it positively. And I'm sorry, there's a garbage truck in my backyard, so if you hear the noise, it's not me. I'm not grinding and grunting. I started using drugs when I was 14. I did youth work for 10 years. I think that society needs to just accept the fact that youth use drugs. And I mean, with the drug poisoning crisis, we're losing a lot of youth, like people who are just experimenting with drugs for the first time, people who are not well-versed in drugs and just buying stuff off the street, and then they're dying. And that wasn't a problem that most of us had when we were young, when we were teenagers and youth. And so first of all, just accepting that youth use drugs and that we need to get over like the cultural squeamishness about enabling and that sort of thing, and just like make safer supply programs and harm reduction resources available to people that are as young as 12. There are people in this province that are 10, 11, 12 years old who are injecting drugs. It's just happening. And that's something that we need to just accept. Obviously, there's issues that are going on there that are contributing to this sort of behavior. Not that it's necessarily, I mean, it is a negative behavior for a 12-year-old to be injecting drugs, I suppose, but we need to just accept that this is going to happen. And in terms of making a safer supply program that's accessible to youth, like going back to the value of trust, like using trusted youth workers from resources that the youth respect, like find out from the youth that are living on the street and from the youth that are using drugs what resources they trust, what resources they don't, and engaging those resources in the provision of services, making sure that that the staff are there who are compassionate, who are non-judgmental. And really, like, I think staffing and locations are going to be the two biggest qualities that are going to make a safer supply program that works for youth and teens, because you don't want to be mixing them in with the older, more seasoned street population, because that's a recipe for disaster. But you also don't want them to feel like they're at the kiddie table.
So Thanks, Phoenix, for that. The questioner just clarified, saying they were referring to enabling more teens. So I'll just give an answer myself as well, adding on to what Phoenix just said. So this idea kind of around does safe supply increase the potential for new first-time drug users is, I think, kind of what the question is. And so to say that, like, from our research and from other research into diversion or repurposing of drugs, a large amount of that is resold or repurposed within the community of drug users. So it's really unlikely, and doesn't seem to be the case, that these drugs are going to first-time users. And if you think about that realistically, it makes sense. Fact of the matter is, drugs are accessible to most people if they want to use it from the illegal market right now. So the safe supply, it's very unclear that safe supply increases the accessibility of drugs whatsoever. And the second thing to say, I think, is the context of the drug toxicity crisis means, as Phoenix alluded to, if young people are using drugs already. So the fact of the matter is, if they have access to a repurposed safe supply, it's preferable that they're using something that's safer than the illegal market when they have a far greater chance of dying. So that would be my 2 cents on that question. I don't know if anyone else wants to chip in.
Yeah, well, sorry, I know I'm talking a lot, but the other thing is, like, if you take a safe supply program, and like, the thing about drugs and teenagers is that drugs are cool. They have mystique. And if you're going, you know, if you're a 16-year-old and you're going to this cool drug dealer's house, and it's like, you know, this cool, like, underground thing that you're doing that, like, makes you seem older, and like, it's got all this, like, mystique and all this, you know, this subversive feel to it. It's a lot more alluring than, like, you know, you go to a place, it's brightly lit, there's happy people there. It's not, you know, like, if we take some of that mystique and that cool factor out of, like, going to the downtown east side and buying drugs, or going to the drug dealer's house, like, I just, thinking from my own personal experience as a young person who was buying drugs, like, it had a lot of really, I keep saying cool, but there's an inescapable cool factor to it. You know, you're going someplace you're not supposed to be. And so if we take that and just turn it into, like, you're going to a store and you're buying something, I think that takes a lot of that factor out. I mean, then would that push them to the illicit market? I don't know. I mean, we would hope that it would make the illicit market a little less accessible.
Right. Yeah, and I would say one thing about that came out in the section that around repurposing is that repurposed drugs, one of the things we heard is a way of giving people or introducing people to access to the notion of safe supply. We talked to people who had no idea even what safe supply is. And they were, like, embarrassed because they're like, I don't really know exactly what we're talking about. And we discussed the idea a little bit, and they're like, oh, okay. They caught on to that, and they knew more about what it meant to them. But not everybody's familiar with this yet. And so repurposed drugs was a way of introducing people to a different way of accessing pharmaceutical grade drug. Well, we also have findings that we're still sorting through around education, like mutual education, information, like learning. And so if you think about all of these things that come along with safe supply in a community context, then you can think, okay, well, drug access comes along with conversations, relationships, care, education, learning. Like, there's a lot of things that are part of this process of safe supply that are not just there. And also wraparound supports was huge. Like, it's not a surprise, but we heard that again and again, that safe supply is more than just drug access. Though primarily drug access, it's a lot of things in terms of people's survival needs. And so we understand safe supply to be a process of all of that, inclusive. So in terms of, you know, like, youth who are using probably need those secure, trusting relationships. And that's how we would understand safe supply.
I think all of that, I mean, one of the things I think of is supervised consumption services, right? Where once somebody has consumed their drug, they're like, okay, now I can talk. I got what I need, and I'm safe, and I'm okay. And oh yeah, while I'm here, can somebody tell me where like the nearest food bank is? Can someone treat my wound? Can someone give me a housing list, right? Like once that first need is met, then there's space and time, and people are able to then address other things according to whatever their goals or needs are at that time. And securing their medication, their drug in the morning, in the afternoon, in a few hours later. Like when you're caught up doing that, there's not a lot of time for all your other parts of your life. So yeah, that makes sense from that perspective as well. I think, Erin, you made me think about that piece. And I think, we always have to remember where the whole notion of harm reduction and needle exchange or needle needles, I don't know, what am I trying to say? Needles exchange programs, but before they were exchange programs, right? That care that's always happened in the communities in the absence of institutional care and support. In institutional, I mean like access to doctors, nurses, social services. When those barriers were so high and still are so high for so many, people look out for each other. There was really a great example of that even is the wound care training that we did. We put out a wound care training for clinicians, and we got a whole bunch of like, oh, but we're interested in attending a wound care training as well, because we're the ones who actually provide a lot of care for each other and ourselves. So we made sure we had a wound care training for people, for anybody who could come. And so, yeah, making sure that we support that work, but also not abandon people without resources to do that work is really, really important too. I'm curious about other dissemination plans that you have for this. We're going to make sure that we share this, and we'll be posting about this webinar and making sure that people who weren't able to be here today know that they can come and watch it on our website. I'm curious about other dissemination plans that you have so that we are using this knowledge that you are bringing together and producing, putting out into the world, how we can use it to make change.
For sure. We're working on a zine as well. We've got a zine in the works, and also we're working, the whole team is working on a number of journal articles that we're going to be developing. It's an ongoing process, but those are the two that I can think of most readily.
Yeah, and we want to do more of a project launch. It'll probably be this summer with a website and all of our knowledge sharing materials there. Our stakeholder groups, the first stakeholder group is drug user groups. And so we might potentially reach out to do workshops if we can get the funding to do so, for folks to imagine what safe supply looks more logistically in their region. And definitely interested to talk to more prescribers and pharmacists and hear how this lands and what kind of, we've got a lot of information. This was just the tip of the iceberg. And so if there's any aspect of this presentation, you're like, well, I really want to hear about that, let us know, because we can present and share. So we'll have both conferences, webinars, and print publications that we will link through the website when it launches, and we'll definitely let the community of practice know when that's ready to go.
That's amazing. Yeah, we'll definitely be wanting to plug all of that, and we'll probably want to have you come back and talk some more. There are a couple more questions here. Let me just also, you don't have to answer this at the moment because you should talk about it as a team, but there are a couple of requests for the slides to be shared. So if you can let us know afterwards, then we'll make sure everybody knows, and we'll make them available accordingly. There's a question from someone here. How would you address prescriber concerns about diversion? Really interesting to hear it spoken about from a strengths-based lens. Ireland has quite a punitive oat system.
Jack or Sean?
Yeah, I can try for that one. So yeah, I mean, this is probably one of the #1 concerns that comes up when you talk to prescribers about prescribed safe supplies, is the ideas around diversion and potential risks and harms that can result from that. And like Jack went through over in his presentation, you can really flip it on its head, looking at it from a community perspective of caretaking. But you can also, you can approach it from other ways as well. Like, we had participants in our study who really wanted prescribers to really challenge those concerns and maybe spend more time with people that, if they are really concerned about prescriptions being diverted, talk to patients about, okay, why are you not using your prescriptions? Why do you want to repurpose them? Why are you sharing them? Sometimes it can reveal really important deficiencies in the program. Like, these aren't the drugs I want. This dosage doesn't work for me. I don't have enough money to make ends meet every week. And so it can really point to a deficiency in the program to meet the whole body needs of the patient. And, that's why those things are happening. It's not like a problematic individual behavior. It's really a problem of the program and not meeting the needs of the patient. And so I think that a lot of that really also comes back to, like Jack was advocating for, like systemic change. Like, a lot of the pressures that prescribers feel around diversion, that our participants recognize that that pressure comes from above, that comes from the regulatory bodies, where people can lose their licenses, they can be audited. There's like really serious repercussions. And so part of helping to reframe this for prescribers may be needing to do some advocacy in those, institutional actors as well. And I'd love to hear if anyone else wants to jump in. Yeah.
Yeah, I mean, like, feedback is huge. We heard that, there needs to be processes for accountability for the program and for prescribers. Accountability relates to getting feedback and reacting to it. And sometimes that feedback is directed verbal, and sometimes it's behavior. And if people are repurposing drugs, then it's an opportunity, if that person's open and receptive to the conversation, be like, what's not working about this program? And to think about like holistic program goals, like Sean was saying. So I guess the response is like, look internally at that program and think about how to talk to prescribers around practices of care that are working for people. It's like this whole thing on diversion. It's like we were trying to present is why look at people individually? Like, why look at people as bad when it's people are looking to survive? So then that's not a bad thing. So yeah, that's I guess we might have more to say about that in our write-up, which we're still working on, but I think that's probably the primary finding we have so far, is to think about systems change or program change.
I think sometimes though, like, and I just have sometimes a really harsh view of things, like the question that you just posed, people are just trying to survive, and that's not a bad thing. But as a drug user and as a poor person, I often think that they don't want us to survive. I feel sometimes like the poison drug crisis is a type of genocide that is aimed at us. And I have to wonder if a lot of these restrictions are in place because, there isn't a care whether we survive or not. And I know that it's a harsh thing to say, but it's how it feels sometimes.
That kind of neglect that so many people experience at different levels, from practice to policy to funding to all of it. It all trickles down to that experience of feeling that, yeah.
Right. And it's almost like any person who's engaging with the safe supply program, you could talk to that person and be like, what's the shape of the box that you're expected to be fitting in? That either you carry into here, or that the safe supply process is putting on you, and like understanding that as a piece of how someone's experiencing that process, and not looking at them as a problem or their behavior, but looking at like, okay, let's remove it from the person and look at this like imaginary box that's they're being shoved into. Let's address the box. And there's probably a lot of different questions and things that you could address. And then if you move that up to a collective level, like we did in the research, then you start to really understand what's not working here, So it's like, take the onus off the person. Think about how we're removing the weight from the shoulders of this person and we're putting it back on the way that prescribers have the power to address systems change, along with in collaboration with people who are using.
There's another question here. Is there a role for medicalized safer supply model? How does, if so, this medicalized model, how would it relate to a non-medicalized model?
I think there's room for both. One of the things that we've found in this research and in all of the other research that I've done on safe supply is that people want a range of options. We need a number of options that are tailored to different needs and different goals. So a prescriber model could work for one person, and then another person wants one that's more like a liquor store or, you know, a storefront model where they just go, they get their thing and they leave, and it's, you know, it's not about anything else than just, you know, meeting a specific need. So I think that the two models could be integrated. There could be blends, but really we just need a wide range of models that can be accessible to different people.
Yeah.
I'll add to it. Oh, go ahead, Jeff.
Yeah, just to add to what you're saying, Phoenix, it did come up in our research. Some people did prefer kind of medicalized models. So there is a range of needs and preferences when it comes to safe supply. And exactly as Phoenix said, its options are what is needed. And so definitely, I think there is a place for medicalized safe supply. It's just not as the only option that's out there. And to add on to the diverse needs, another example is the needs of people who use drugs in rural locations is going to be very different from in urban areas. So what safe supply looks like could be very different. One example that came up of this idea discussed by a few participants was of a mobile van distributing safe supply in rural areas to kind of get over the distance and geographical issues. That's just one. And another example would be a dispensing machine safe supply, as is in Vancouver. But these are very different kind of models of safe supply, and they reflect different needs. And so there is a place for medicalized safe supply, but as one of multiple options, I think.
Yeah, and I'll add to that, like, it's a good question. How is non-medical related to medical? Like, there's a sort of binary that happens in conversations about safe supply, that when our data shows, like, what are the stepping stones? So how do these models look at confidentiality? Confidentiality is huge. And if you look at people's different needs and options, while that could be met by something more of a prescriber involvement, or it could be blended into some other way. So you could look at confidentiality, location, drug access and how that looks like, or pickup and carries, how that looks like. There's a lot of different factors. It's like, what are the logistics of safe supply? Okay, let's break that down. Let's look at how that would look for a particular community. And it's a way of saying, okay, this is a whole array, and that there might be ways, like Phoenix was saying, that these things are more integrated and less binary than we actually think they are. And when we're talking about safe supply, it's like, okay, well, let's just talk about the factors that go into it and start the conversation there, because it gives you a lot more nuanced ways of understanding the breadth and the scale of everything that logistically could go into it. So we look forward to detailing all of those kinds of findings when we share our research more, because it's like, these are tools for discussion for program design. Yeah.
To pull on to that, like, your questions, your ethical questions are fantastic. And I think they're going to be a really useful tool. And I'm already thinking about how we could bring in those questions to a couple of our different meeting spaces that we have amongst our members. Yeah, Phoenix, what are you going to say? Yeah.
Just agreeing.
Yeah. We have, one of the meetings we have is a program operators meeting, and I'm thinking it might be a good exercise for us as a group, a diverse group from across the country and different models and things to talk about that. Particularly because I'm trying to figure out how to word this. You know, we're coming into, I think the next couple of years are going to be pretty hardcore for the harm reduction drug policy community. And we have a lot of work to do. And I think a lot of advocacy work. I think it's really crucial right now that we do make sure that we are pushing and that we're supporting the community's push for the different types of care services options, for treatment, for safe supply, for primary care, for social services, for housing, et cetera, et cetera. And I think, you know, we need to, in terms of the medical model of safer supply, making sure that we are supporting a model that continues to meet people's needs instead of having it get co-opted by, you know, care as usual kind of thing, the more traditional approaches. I think we're going to have to really, I'm just thinking about like what's happened with the narcotics transition service in Alberta, for example, sort of taking over safer supply. We want to resist that. And so, yeah, I think studies like this are really important for providing the evidence and bringing the ideas together that we can call on when doing that advocacy. So thank you very much for this work. It's 4:27 in the Eastern time zone. I guess that's what, 1:30 for you in BC, Phoenix, and 5:30 for me in Atlantic Canada. So we're going to be bringing this to a close now. I'm really grateful for all of you being here. I've been really excited about this study and really looking forward to hearing your findings and how you've been working through everything. And I'm serious about being in touch to bring you back in a few months when you have a few more pieces out that you could come back and talk about with us. So thank you so much. In the chat, my teammates, my amazing teammates, are posting about a certificate of attendance and the very valuable to our team survey. We really appreciate all the people who fill out the surveys for us. That's really helpful from a programming perspective, and also helps support our when we tell our funders that we want to keep going and we have things to do and needs to fill. So yeah, thanks for that. And I hope that we get to see you at our Hot Topic webinar at the end of the month. Team member Alex or Robin or Spola, can you throw in the link to the registration for that? And I also invite everyone to go to our website where you can always find out what the next upcoming webinar is by going to our upcoming events listings. You'll also find our resource library. You'll find under past events. This video will be there with the slides from the team. Thanks for sharing that. And with that, I'll say goodbye to everyone and wish you all a good week.
Thanks, y'all. Bye.
Thank you.
Bye.
What a great group.